hopefully everyone can hear me now. I was saying that we care about CAKUT, or congenital anomalies of the kidney and urinary tract, because they account for a significant portion of end-stage kidney disease in children. Glomerulonephritis here at 32% really kicks in later when we get into the preteen and teen years as you're approaching adulthood. So in the younger kids, this is our biggest cause of end-stage kidney disease. So now I'm going to go back and track through what I mentioned earlier, the different stages. So abnormal renal parenchyma, what's happening here? You have this malformation of the, for lack of a better term, kind of the meat of the kidney, the part that's not the collecting system, but where the glomerulus is, where a lot of the work of what the kidney really does happens. And so you can have developing what's called a multicystic dysplastic kidney. And I will apologize, some of the terminology is confusing because we'll talk about cystic dysplasia that's different from multicystic dysplasia and why they didn't differentiate those with better terminology. I have no idea. But multicystic dysplastic kidneys can be seen. And then you can see cystic changes from genetic diseases, the ones that we tend to hear the most about, autosomal recessive and autosomal dominant polycystic kidney disease. And then there's a disease called nephrology as well. You can also see cysts that develop secondary to obstruction, but that's a different process. And then alterations in renal size is another manifestation of abnormal parenchymal development, going anywhere from the extreme of the kidney not developing at all, renal agenesis, to it developing but not fully, being a little bit small, which we call hypoplasia. So touching on here the issue of the solitary functioning kidney, and I'm using this figure that I took from this paper in Nature Clinical Practice Nephrology that I think nicely illustrates the different issues here. So from the very first slide that I showed you, where we talked about the mesonephric duct, which is where the ureter and collecting system develop from, and you have the mesonephric mesenchyme. These are the two pieces that you need. And in this diagram, solid lines mean that's normal development, and the dotted lines are abnormal development. So if you do not get appropriate metanephric mesenchyme or mesonephric duct, you end up with complete agenesis. If things go normally here and you go to the ureteric bud and start seeing branching for the collecting system, and then the nephron precursors here, normally this should go on and give you a completely normal kidney. We mentioned hypoplasia, where the elements of the kidney essentially look normal, but they're just smaller than they ought to be. And then here's where we talked about the confusion of this terminology, cystic dysplasia here versus a multicystic dysplastic kidney. The way cystic dysplasia is differentiated is that these kidneys will have a collecting system that's identifiable. With the multicystic dysplasia, there's no collecting system identifiable. You just see this bunch of cysts here, but you don't see an identifiable collecting system and renal pelvis as you do here.
So it's by definition non-functional.
The multicystic dysplastic kidney is completely non-functional by definition. And there are acquired forms, but we're not going to touch on those because that's not relevant to our discussions here from the fetal standpoint. The other piece that's important with these solitary kidneys is that if you do develop an abnormal kidney on one side, very often there are abnormalities in the other kidney as well. So it's just because one is abnormal and the other one may look okay, you still need to check to verify that that other kidney so some of the abnormalities you can see on the contralateral side of that abnormal, of that dysplastic kidney. The other kidney can have issues with vesicoureteral reflux, maybe ureter obstruction, could be a duplex kidney on that side, and I'll touch on some of these a little later. There can be extrarenal manifestations. Sometimes these kids will have GI abnormalities. They can have ear abnormalities, depending on if you're dealing with something syndromic in many cases. And there can be female tract and female genital abnormalities as well. So the renal dysplasia, and my focus here is not going to be so much on the images, although we do have to touch on them to make the case. So this is an MRI image of a dysplastic kidney. And so you can see that clearly this kidney is a lot smaller than this kidney. And the way we evaluate these kids once they're born is you want to check electrolytes, you want to consider doing a VCUG because, as I mentioned, often the other kidney has an abnormality, so you want to rule out any reflux in that other kidney. Consider a radionuclide scan to look at function. People usually recommend also that you do serial renal ultrasounds because you want to assess whether the contralateral kidney is growing appropriately. Blood pressure and a urinalysis to check for proteinuria on an annual basis is really important. Again, you want to be able to detect as early as possible when these kids are starting to show abnormalities. And so the prognosis depends on whether the dysplasia is unilateral or bilateral. If it's unilateral and the other kidney is completely normal, prognosis is actually quite excellent. If it's bilateral, then they are at risk for chronic kidney disease. So the multicystic dysplastic kidney that I mentioned earlier, we see in about, on average, 1 to 2,000, 1 to 4,000 live births. Again, high rate of contralateral renal abnormalities with vesicoureteral reflux and ureteral pancreas junction abnormalities being the most common. And you want to do a postnatal ultrasound to confirm. And this is grossly what one of these kidneys looks like if it's been removed. So you can see here what you typically see are these strips of varying sizes, and they don't connect to each other. And that's why you don't have any drainage, because they don't ever get together and all flow into one place into any type of excretory function. So what happens to these kidneys? Most of them actually involute. It can be over less than a year. Some of them take up to 10 years to involute. What you want to look for, and one of the reasons for this serial renal ultrasound, is that the other kidney, you want to see some compensatory hypertrophy there. That other kidney ought to start getting bigger. It should be bigger than a normal kidney is because it's got to do more work. And so if you don't see compensatory hypertrophy, it really would make you suspicious that there is something wrong with that kidney if it's not growing at a faster rate than you would expect under normal circumstances. So then you have to worry whether that other kidney has some hypoplastic elements to it as well. The kidney function in these kids, if that contralateral kidney is normal, their kidney function will be pretty much normal, although there is a subset that may develop mild or moderate kidney disease. It used to be thought that these kids had a propensity to develop hypertension. We now know with longer studies over time that their risk for hypertension is actually the same as the general population. Similarly, it used to be thought that there was an increased risk of malignancy in these kidneys, which is why they used to be removed. They generally are not removed now because the malignancy risk, again, is not really any different than the general population, about 0.03 to 0.1%. And like I said, most of them will just involute. There's no reason to remove them. And often in adults who are being evaluated for other reasons and they're told that they only have one kidney, it's thought that many of them may have started with multicystic dysplastic kidney that just involuted over time, and they're only just being found out later on. So the general recommendation for evaluating these infants once they're born is to do a renal ultrasound at about 48 hours, repeated at about 4 to 6 weeks, because you want to see if there's any contralateral abnormality. If the contralateral kidney looks fine, just follow them conservatively with the annual check. But if that other kidney looks abnormal, get a BCG, consider a diuretic renography. It's generally not recommended that they have prophylactic antibiotics, but you want to counsel the families about the signs of urinary tract infection, if they should stay on top of that. Now to move to autosomal recessive.
Just one question. So if you had a history prenatally and you get 1 or 2 follow-ups that it involutes, you just send them away. You don't need to follow them for blood pressure. They don't need to be on any low-salt diets.
No, we do recommend that. So if it involutes and they're left with just a single functioning kidney, you do want to follow them, keep a close eye on their blood pressure, make sure they're not developing proteinuria. Most of them will be fine, but we know that there's a slight increased risk, so you do want to track blood pressure, give them lifestyle counseling.
So they should get lower salt.
Right, and not taking a lot of NSAIDs, trying to watch their weight, all of those things. The things that we ought to be doing anyway. Yeah. But you want to particularly point that out to people that yes, you have this one kidney, and the dogma is, oh, we only need one kidney to survive, and that's why people can donate. But we now know over time, even if you follow people who donate a kidney, if you track them long enough, that they have a slight increase, but it's not exactly the same as the general population. So people who donate a kidney are told, given advice on these lifestyle issues as well, and staying away from NSAIDs and the rest.
So just, one more question about multicystic. So that tissue is parenchymal tissue only without the metanephric component. Is that right?
It's parenchymal tissue. It's metanephric tissue that's gone awry.
Without the blood.
It's not, but it doesn't have the ureteric blood, and it's not developing the collecting.
So the cysts, what is the lining of the cyst? Is that lining?
It's epithelial lining, but exactly what and how, it's thinned out. They're dysplastic. And what's thought is that the whole proliferation has gone awry, not in exactly the same way as with polycystic kidney disease, but again, there's something that's gone awry that allowed the proliferation to go out of control as opposed to the normal division that you should be seeing that shouldn't develop then. But it doesn't seem to have the genetic cause of the cyst proliferation as you see with polycystic.
And it has a normal arterial supply?
No.
Not typically.
And so with the imaging, for example, with the if you were to do a renal scan to look for function, it's completely blank on the renal scan. So if their other kidney has function, you'll see on the scan, it'll look like someone with only one kidney, even though in ultrasound you know that there's an organ of some sort there. And so that's one of the pathognomonic things that you can see is on ultrasound, you're seeing what looks like two kidneys. But when you do the renal function scan, you see only a single kidney. Nothing shows up on that.
On the prenatal image, we don't see an artery to that kidney either. We look for a renal artery, and we don't
Okay.
So the autosomal polycystic kidney disease, autosomal recessive, I should say. So this is caused by a mutation in a gene called PKHD1. And this gene forms a product, a protein product called fibrocystin, or in some of the books you'll see it referred to as polydustin. And what the gene product is thought to do is help to control things like proliferation and migration and development of the kidney tissue, and it goes awry, and you end up with these cysts. It actually interacts with the gene product that goes awry in autosomal dominance that I'll come to in a minute as well. But the cysts that you see in autosomal recessive polycystic kidney disease are primarily in the collecting duct. They're isolated to the collecting duct. These kidneys are huge, and these children also have issues with their liver. There's biliary dysgenesis and fibrosis. So here you see this ultrasound image where the kidneys are literally touching each other. And here's a pathological specimen. And, you know, here's an image of a baby with autosomal recessive polycystic kidney disease. So the big issue with these infants is usually their respiratory status for multiple reasons. One, if those kidneys aren't functioning properly and, you know, they don't get a lot of urine, and there's an issue with oligohydramnia. But the other is also just the physical impingement on the pulmonary space. These huge kidneys are pushing up against the diaphragm, so they just can't imagine trying to take a breath against those huge masses that are in your abdomen.
So that's not ascites plus kidney.
That's not ascites, that's just kidneys. That's just kidneys. And so it's really important to do a respiratory status assessment, the usual look at kidney function, the postnatal abdominal ultrasound. These kids tend to have hypertension, and I'm going to touch on the clinical presentation in a second. So you want to do supportive care. The recommendation for controlling their hypertension is to use an ACE inhibitor. They can be hyponatremic. They can have feeding issues, again, impingement. You know, the stomach is being squished by these huge kidneys, so they can't take in much. They eat, they're vomiting, and so those who present with quite severe disease, you may have to start renal replacement therapy even in that early period. And the prognosis depends on the degree of their renal hepatic involvement, but quite honestly, the very early prognosis depends on their pulmonary status, and often we will look to see how they're doing from that standpoint as you determine whether or not you need to make to start dialysis or any other type of renal replacement therapy. So these are the clinical and imaging features that you see, and I borrowed this slide from Lisa Gay Woodford in the CTSA, and you all probably know that her area of expertise is genetic kidney diseases, particularly polycystic kidney diseases. So the recessive form, because we don't use the term child or neonatal or any, we just define them by the genetics, not by the age of onset, like it used to be called adult versus childhood. So it's autosomal recessive. The onset is typically in the perinatal period, but you can also see it in the adolescent and adult period. Hypertension is very common, as I mentioned. The majority of them will go on to end-stage kidney disease before age 20. A lot of issues with urinary tract infection, with nephrocalcinosis, and the hepatic fibrosis is absolutely found in all cases. I showed you an image of the ultrasound in these kids, and they can have small round macrocysts that you see with age. The liver, you can see changes in the echotexture of the liver. They can also have bile duct dilatation. And I should mention,
I was going to ask you what the long-term outcome of the liver disease is.
so that's what I was just going to mention is that these kids, usually the highest mortality is in the first month or so. And usually if they survive the first month, they've got about an 80% chance of, surviving into teenage years. What we see now, because we have the ability to do dialysis and everything else to deal with the kidney aspect, the liver aspect is now becoming more of an issue as they get older and their liver disease gets worse. So there's a whole spectrum of severity of their liver disease and the fibrosis and developing varices in the esophagus because of all the other things that are going on. So the liver issues are now becoming a bigger deal than the kidney issues were. In the past, what they died from was kidney failure. And now that they're living longer, you're seeing more and more of the liver problems with this disease. And so, the GI folks are getting much more involved in taking care of children with autosomal recessive polycystic kidney disease. So the clinical part, it's unusual to see isolated hepatic fibrosis in the younger kids. You can see that in older age groups, and I mentioned some of these others already, the hypertension, proteinuria, problems with urinary tract infection. The variceal bleeding that I mentioned just now, you see usually in the later years, not so much in the younger kids. And then autosomal dominant polycystic kidney disease, more common than autosomal recessive. There are two genes that seem to cause this abnormality. One is a mutation in the PKD1 gene, which makes the protein polycystin 1, and that accounts for about 85% of people with autosomal dominant polycystic kidney disease have that mutation. The other 15% or so have a mutation in the PKD2 gene, which is the gene for the protein polycystin 2. The polycystin 1 and polycystin 2 interact in a similar way to the PKHD gene that I talked about in autosomal recessive, again, to try and control the growth and movement and proliferation of the renal parenchymal tissue. And so when these genes mutate, that growth gets out of control. Unlike the recessive form, where the cysts are isolated to the collecting ducts, the cysts in dominant disease occur along the entire nephron. They can be anywhere along the nephron. Similar workup that you're going to do, look at kidney function, the abdominal ultrasound. If there's no family history and you find kidneys that look like this, consider that there may be some other type of cystic disease in the family. Supportive care, similar to what you see with the recessive, with attention for blood pressure. But people with dominant disease are likely to have preserved function until they're in their 40s and 50s. It's unusual to see end-stage kidney disease from the dominant disease early on. So you can see the disease early on, but their function actually tends to be okay for quite a while. I think I've touched on most of this. About 25% will go to end-stage kidney disease who have the early onset, but it's more common to see that in the adult age range. This is the one that's associated with aneurysms, intracranial aneurysms. And even though, you know, we're taught to be concerned about these, you see it's actually not that common. But if you find it, you really do have to follow these people quite closely.
So you're saying if it's a child presents with this, they have a less incidence than an adult who develops kidney disease for the aneurysm?
Yes, the aneurysms in childhood are quite rare, and so when you start to see them, it's later on. So now, talking just very briefly about the anomalies of renal migration, and basically you end up with ectopic kidneys, just meaning they're not where they're supposed to be. Some of them stay down in the pelvis and don't migrate up. You can have them being fused, forming what's called a horseshoe kidney. And you worry about that because those tend to be more midline, more in the front. They're not protected by the ribs, so there's an increased risk of injury. These also can have other anomalies because they haven't migrated to where they need to be. The ureters haven't kind of stretched up like they should, so there are more instances of reflux and obstruction because the ureters are sometimes kinked a little bit. Just, again, they haven't moved up to kind of stretch them into the position they're supposed to be. These horseshoe kidneys also, for some reason, can have an increased incidence of stones and of urinary tract infection. So abnormalities in the collecting system. So these are the ones that you probably see the most referrals. There are urinary tract dilatation detected in up to 2% of all pregnancies, and most of the time it's transient. It has no clinical significance, and often if, you know, the next ultrasound, it may have gone away and you'll see it waxing and waning. But the ones that do have clinical significance I've listed here. Clearly, if you've got some type of true obstruction, that's got clinical significance, whether it's at the ureteral pelvic junction or the ureteral vesicle junction. Reflux has clinical significance if it's severe enough, and we'll touch on that in just a second. Neurogenic bladders, posterior urethral valves, a big issue, and the megaureter ureteroceles can be of clinical significance as well. So we'll start with vesicoureteral reflux. There's this international grading system that shows here, grade 1 being that urine is going from the bladder up the ureter, and it gets up to the pelvis, but goes no further. Grade 2, it goes into the pelvis. Grade 3, it's in the pelvis, and you start to see some changes, some blunting, instead of these being nice and sharp. And grades 4 and 5, just worsening of those, with grade 5 having this very tortuous ureter. So grades 1 through 3 actually have a very high likelihood of resolving spontaneously, and you just follow these kits conservatively. Grades 4 and 5 often require surgery, and so it's recommended that, you know, you refer grades 3 or higher to urology. While grade 3 may resolve spontaneously, the likelihood of the resolution is less than for grade 2 or grade 1. Prune belly syndrome. This is the syndrome that's named because, you know, the belly ends up looking like a prune. The musculature is very poorly developed. There are lots of theories about what causes prune belly syndrome, and to be honest, we still aren't sure which is correct. So one theory is that you have an early obstruction in the urethra, and so, you know, as the bladder fills, it becomes very distended, and that impedes proper stomach muscle, abdominal muscle development. There's another theory that it's actually the reverse, that the inciting problem is the abdominal musculature doesn't develop properly, and so that allows the bladder to kind of fill and become large, and you run into these other problems. And then there's a third school of thought that there may be some overarching problem, whether it's a neurologic issue or whatever, that's impacting the musculature as well as the urinary tract, and there may be one unifying theory, but nobody at this point really knows which of those is correct. What we do know is that there are a lot of associated abnormalities. So GI abnormalities include things like volvulus, malrotation, gastroschisis, pulmonary issues, similar to what we see in other cases where there's not a lot of urine output and you may end up with oligohydramnios. These kids can have pulmonary hyperplasia as well. They can have cardiac abnormalities, ASCs, VSCs, tetralogy, and orthopedic problems, club feet, pelvic dislocations, a lot of abnormalities associated with this. And this is a problem seen almost exclusively in boys, although occasionally you'll see a female infant with this. Posterior urethral valve, the most common cause of chronic kidney disease due to urinary tract obstruction in children. So you can see the dilatation there on the ultrasound, the thickened bladder wall. This, we generally recommend that, you know, very early referral to pediatric urology, because if they can go in and visualize, if the baby is large enough that they can actually do a scope and visualize it, they can do the valve ablation right then and there and relieve the obstruction. If that's not feasible, then some type of urinary diversion, usually a vesicostomy, again, to relieve the pressure of backflow onto the kidneys and try to minimize damage to the kidneys. And you can see the post obstructive dilatation there. You see so you see here the clear obstruction and then the dilatation beyond that. The ureterocele, this is probably the only one that's more common in girls than boys. And what it is you've got this ballooning of the ureter where it enters the bladder, and you end up with this ballooning here. You would confirm with a VCUG, because often these are associated with reflux. Again, the pediatric urologist, if they can scope, they can incise that ureterocele and collapse it. And these are often associated with the duplicated collecting system. So you see here, this lower system is going in and has a normal ureteral orifice, but this dilated system at the top is associated with this ureterocele here. So it'll give you obstructive symptoms. You see that this is clearly obstructed, and in some cases you can have reflux in the lower pole as well. So the general evaluation of all of these kids, especially if they have what were called features of Potter's sequence, where you have the wide nose bridge, the epicanthal fold, low for whatever reason. So they're not unique to any one particular cause of oligohydramnion. And again, good physical exam to look for, is the abdominal musculature normal? Can you feel the kidneys? Can you feel the bladder? Things like that. And so, again, postnatally, serum creatinine, generally, if there's bilateral renal disease or you have a solitary kidney that doesn't look normal, just remember that the serum creatinine, if you check it right at birth, is really going to be mom's creatinine, not the baby's creatinine. And it should come down to normal by about a week in term infant, 2 to 3 weeks in preemie. And I just wanted to touch very briefly, when I talked about environmental issues that can affect as well, one of the big things is prematurity. So what I've been talking about here, to this point, is CAKUT. And that alone can give you reduced nephron numbers, or what we call oligonephropathy. If you're premature and you're low birth weight, that can give you low nephron numbers. So imagine now you're combining this with this, then you go to the NICU, you get a lot of nephrotoxic medications that you need, but they are often nephrotoxic. There are hemodynamic changes, so you can end up with acute kidney injury. You end up with hypofiltration, glomerular hypertension, you get systemic hypertension, proteinuria. You lose even more nephrons as they sclerose, and you end up with chronic kidney disease. I just, we didn't have, the point of this talk wasn't so much about this, but I did want to touch on that when you complicate CAKUT with all these other things, it just puts the kid even more at risk for developing chronic kidney disease. So take-home messages: CAKUT, leading cause of end-stage kidney disease in children. Early detection allows you to hopefully prevent, but at least slow down progression to end-stage kidney disease, and to prevent the complications that are associated with end-stage kidney disease, which are many, which we can touch on during the Q&A if we have time. The long-term follow-up, we want to pay attention to their blood pressure, development of proteinuria. Those are going to be the early signs that there may be some renal dysfunction going on, even before you see any change in their creatinine level. And I think that is my last slide. So thank you.